So let's start today's program. We're starting it today with a brand new friend of WPA. We're excited. Dr. Eric Jackowiak. Dr. Jackowiak is a movement disorder specialist who recently joined the team at Froedtert and the Medical College of Wisconsin, as well as the VA Medical Center in Milwaukee. He researched the impact of deep brain stimulation on Parkinson's caregiver and has a special interest in educating future neurologists. Welcome, Dr. Jackowiak.
Thank you for that introduction. Hopefully everybody can hear and see me okay. Today I will be discussing new and emerging treatments in Parkinson's disease. I do want to give a special thank you to my team here at the Medical College of Wisconsin. So that includes Dr. Blindauer, Dr. Eichenseer, Dr. Brennan, and Michelle Westline, who all chipped in and contributed to these slides in this presentation. So before I begin, also just want to mention that I do not have any conflicts of interest to disclose. Specifically, I don't have any financial relationships with any of the pharmaceutical companies or device companies that we'll be talking about today. And a further disclaimer, just because we will be talking about a lot of different treatments, both medications and procedures, it's important to remember that individual needs are different. And so what may be appropriate for one person with Parkinson's disease may not be appropriate for another. Also, that different providers have different preferences. So even faced with the same situation, different providers might recommend or decide to do or use different types of treatments. I also aim to be objective on everything that I talk about and just really present the information. And so just because I talk about something, that's not necessarily an endorsement or I'm saying that I think everybody should be on this medication. An outline for what we're going to discuss today. I'll start with a background on the research process, followed by an overview of what the current status of treatment in Parkinson's disease is, just as a framework so everyone's on the same page when we discuss the new treatments and see how those fit into what we have already. Then I'll move on to discuss some of the new or recently approved treatments, and end by looking into the future and see or discuss what's in the pipeline and what might be available in the future. So to begin, a background on the research process. When we talk about research for any condition, not just Parkinson's disease, there are two really main elements. The first is the pathogenesis. And what I mean by that is really just our understanding of the disease itself. So that's research into figuring out how the disease starts, but not only that, how it progresses and how it impacts the body. Along with that are the study or trying to identify biomarkers, and this is very big in Parkinson's disease. Looking for, be it a chemical in the blood or the spinal fluid or an imaging finding that can be used to, one, potentially detect the disease and ideally detect the disease early in the process, but also measure and gauge progression of the disease. I'll be talking more about the second element today, and that's the treatment. And these include medications or different procedures. In Parkinson's disease specifically, we break down different treatments into whether they are symptomatic treatments, meaning they're purely to improve the symptoms, make you feel better, or whether they are disease modifying, meaning that they are actually impacting the disease process itself, aiming to slow, stop, or reverse the progression. So clinical trials, looking at treatments for any condition, but Parkinson's included, really is a process. So this starts in the preclinical phase. These are things like basic science research in the lab, looking at different chemicals, how they work or interact with the cell, but also then moving on to potentially animal studies, looking at how they work, are they safe, etc. Once you get through all that preclinical phase, you can enter the human trials. And so those have various phases, which I'll discuss in a little bit more detail in the next slides. But once you get through the initial phases, that's when the drug could be submitted for FDA review. Even after it's approved and in use, there's still always this phase 4, which is the post-market surveillance, still continuing to evaluate for safety, et cetera. So the phases of human clinical trials starts in phase 1, begins with really just a small number of healthy volunteers or patients, and the main patients with the condition. The main goal here is to get information on safety, also to figure out appropriate dosing and side effects. After that is phase 2. So this is a little bit bigger study, more patients. Still, the primary goal is safety and tolerability. However, we can start to gain some insight into if the drug or the treatment works. Important to note that only 1/3 of treatments successfully pass through these first 2 phases. When we get to phase 3, this is really the pivotal study. So this includes a much larger number of patients, so hundreds or thousands, confirming the efficacy or how well the treatment works. Also continuing to look at side effects and safety. If it's successful in this phase, after this stage is when it would be applied to the FDA, and the FDA can decide whether to approve or deny it for use in the United States. Want to also mention that really only 10 to 20% of treatments succeed past this stage and go on to be approved by the FDA. So now I'll move on and talk a little bit about what are the current status of treatment for Parkinson's disease. Now, I mentioned earlier that there are 2 types of treatments, symptomatic and disease modifying. And where it stands right now in Parkinson's disease, we only have symptomatic treatments. So everything that we give are to improve your symptoms, improve your functioning, but it's not affecting the underlying disease process or not slowing the progression. The mainstay of our treatment is to increase dopamine in the brain. The hallmark features of Parkinson's disease are loss of the neurons or the cells that produce dopamine. And so our main goal is to make up for that. For 50 years, the mainstay has really been carbidopa-levodopa. It's, despite it being around for that long, it's really still the main drug we use in treatment of Parkinson's disease. Now, it comes in different formulations. The brand name Sinemet, some of you may be familiar with, but also comes in just generic carbidopa-levodopa, comes in a regular or an immediate release form, comes in a controlled release form. More recently, there are formulations, the brand name Rytary is a mix of the more immediate and controlled release forms. There's also an intestinal gel, which is a continuous infusion into the intestine through a pump of this medication. There are also dopamine agonists, which are synthetic chemicals that still work at the same receptors in the brain as dopamine, with the goal of having the same effect. Finally, MeO-B inhibitors. These decrease the breakdown of dopamine in the brain, really only used as a sole or monotherapy early on in the disease course, meaning that they're used by themselves without anything else. So that's the mainstay, is increasing that dopamine. However, as the disease progresses, there are changes that typically need to be done to the treatment regimen. And these are to address the various complications of Parkinson's disease. And when I say complications, this can mean a number of different things, but it includes motor fluctuations. So those are on and off periods. On meaning when the medications feel like they're working, you can move, you have less tremor, etc. And off being the opposite of that. Dyskinesias, so these are the involuntary or extra uncontrolled movements. So think about the extra movements that Michael J. Fox commonly has when you've seen him in interviews. These are dyskinesias. Other complications just include other side effects of treatment and also the non-motor symptoms of Parkinson's disease. So things like sleep disturbances, mood, anxiety issues, cognitive changes, psychiatric symptoms. So there are other things that can occur in Parkinson's disease as well. The current treatment of these complications in terms of the motor fluctuations or the on-off periods, there's several different things you can do. One, you can simply increase the amount of medication you're giving or how frequently you give it. You can combine different classes of drugs together. When I say combined dopaminergic drugs, I mean like the carbidopa-levodopa or the agonists. You can also use drugs that then decrease the dopamine breakdown. So I mentioned the MAOB inhibitors, but there are also COMT inhibitors. This includes things like entacapone or Comtan. And there are also rescue therapies, so medications aimed at kicking in quickly for those who have either sudden or unexpected off periods. Also surgical therapies, so such as deep brain stimulation, that can be used once you get into these complications. Dyskinesias, one thing that you can do is reduce medications if possible. Many people are able to reduce medicines. You can also use medications to suppress them. So amantadine is one of the main drugs used for that cause. And likewise, we can use some of the procedural therapies such as DBS. Non-motor symptoms, those are really symptom specific, and I'm not going to get too much more into that because I believe there was another talk on that. So with that framework, that background, I'll move on and discuss some of the more recent medications, anyway, that have been developed and approved by the FDA. And when I say recent, I went back within the last 5 years, so going back to 2016. So here on this slide showing 2016 to 2018, you can see there are several new medications that hit the market for Parkinson's disease. And I'll go through each of these briefly here. So the first was Nuplazid or pimavanserin. This drug is used for psychosis in Parkinson's disease. So that's hallucinations and delusions. This was a need, as the large majority of antipsychotic medications that are traditionally used, that are out on the market, really should not be used in people with Parkinson's disease because they can make the motor symptoms worse, meaning they can make you slower or have more tremor. So that came out in 2016. There was also in 2017 a new MAOB inhibitor called Xadago or sulfonamide, that is like same class as selegiline or rasagiline, the other MAOB inhibitors. The next two are used for dyskinesias. So these are extended formulations of amantadine that I mentioned earlier, so Gacovri and Osmol XER. And then finally on this slide is a rescue therapy, and it's called Inbrija. This is the inhaled form of carbidopa-levodopa. Again, these are used for sudden or unexpected off periods with the goal that it would kick in faster than what your other medicines might to recover from that off period more quickly. I'll focus a little bit more on some of the even more drugs have come out within the past 2 years here. And so you can see there are 3 drugs that we'll discuss in more detail. So the first is istradefylline, or Nurians is the brand name. This is a brand new class of Parkinson's medication. It blocks the chemical adenosine, which boosts dopamine levels in the brain. The goal or the purpose of using this medicine would be to reduce the total amount of off time during the day. This would be a once-a-day medicine. It's an add-on to carbidopa, levodopa. Important to note, all of these drugs, do have side effects. Many of these that we mentioned are add-on or supplemental medications to levodopa. And so oftentimes the side effects are similar to what we would see in levodopa. So these would include dyskinesias, dizziness, nausea, even some hallucinations or insomnia. Another drug that's been approved, although is not yet available in pharmacies, is opicapone, or Agentis is the brand name. This is a COMT inhibitor, which I mentioned earlier, is similar to entacapone, or Comtan is the other COMT inhibitor, which is commonly used. This prevents the breakdown of levodopa. So the idea is that it's used as an add-on to carbidopa, levodopa to make it last longer and ultimately reduce the amount of off time during the day. The difference between this and entacapone are how often you have to give it. So entacapone usually has to be given multiple times during the day with carbidopa, levodopa, whereas this is just a once-a-day medicine. And likewise with what I mentioned earlier, the side effects can be similar to levodopa because it kind of potentiates its effect. Next is another rescue medicine, and this is Kinmobi, or sublingual apomorphine. Well, some of you might be familiar or have heard of apomorphine before, because the same drug is also used in a different formulation for rescue periods, for off, and that's with the Apokin injections. Same drug, same idea, however, it's just a different mechanism of delivery. So rather than using an injection or a needle, this is a film that goes under the tongue. The onset is quick. That's the idea. That can, onset in as little as 15 minutes with the effects lasting up to 90 minutes. The idea is not that this is used to replace your other medicines or used throughout the day, but more take it when you need it and hopefully give you time for the other medicines to kick in. One of the main concerns with this medication, Apokin, similarly is the nausea, but also has similar other side effects to the drugs that I mentioned before. Okay, and so beyond medical treatments, there have also been advances in procedural or surgical treatments within the past several years. And so again, I'll show you a timeline over the last 5 years of different things that have become FDA approved. And several of them are DBS, or deep brain stimulation, and I'll discuss those in more detail in the next slides, as well as a newer type of procedure, which is the MRI-guided focused ultrasound, which I'll also address further. So deep brain stimulation, if you're wondering why we're calling this a new treatment, it's been around for a while now. However, there continue to be advances or improvements in technology. There are now multiple device manufacturers. So those are Medtronic, Abbott, and Boston Scientific. All have different devices. Now, they all have slight differences to them and potential advantages to their use. In general, when we talk about these devices, there are several differences that you can discuss. One is the ability to have the battery be recharged, or recharge, without having to have a surgery to replace the battery. There are also different ways to adjust the stimulation or change the current. And that's on more on our end when we do the programming. So just to kind of throw out some terms, I'll try to explain these as best I can. Interleaving would be, stimulating from multiple contacts at the same time. Directional leads, which allow you to change the position of the current of where you're stimulating with a little more precision. And fractionalization, also a way to change the current. I'll try to show that it's kind of difficult to describe just with words. So these are the ones on the the four on the left are the ones that are available among the ones that I mentioned. The black on the electrode are where are the different contacts where you can actually stimulate from, and so you'll see they're all slightly different. So one has just 4 contacts. Another actually has 8, or the Abbott and the Boston Scientific have 8, and that allows for more of the directional stimulation. Boston Scientific is the one that I mentioned. You can fractionalize the current. However, there's more in the works here. So if you look to the right, at least that have been studied, looking at putting in even more contacts, or different ways that we can adjust the current. And the ways that this is beneficial is really just to fine tune the area that we stimulate, so we can find the region that's the most helpful, and also minimize the side effects. Also in the pipeline by Medtronic is the sensing technology. So not only can the electrode deliver current, but it can also record brain signals. So that's an area that is developing, and we'll see. It's not clear, at least to me, how specifically that will be used to change the current, but it's an exciting development and in advance. And so then the MRI guided focused ultrasound procedure was also approved recently. This is not a surgical procedure in the classic sense of the word, in that there are no incisions, not putting any hardware into the brain. However, it's still a procedure. And so what it uses are ultrasound waves to actually create a lesion or a scar in the brain. And it targets the similar or same areas that we would use for DBS or deep brain stimulation. The differences here are we're not leaving an electrode in the brain. You don't have a battery under the skin. It's a one-time surgical procedure. So those are the pros. Some of the cons, because it's a one-time procedure and it's a lesioning procedure, it's not reversible, or we can't adjust the regions involved like we do with deep brain stimulation. We also only do it on one side of the body, and right now it's only for tremor in Parkinson's disease, or tremor predominant Parkinson's. So basically it would be used for if there was to treat tremor in one limb. Okay. Now from there, I'll go on to discuss some of the research that's ongoing and things that may be coming. But before I talk about specifics, just in general, I want to bring your attention that there's a lot going on in Parkinson's disease research. So this is from the website clinicaltrials.gov, which anyone is welcome to get on and see. You can search for Parkinson's disease and search by region and see, how many different studies or what studies are going on. I just did a search myself in the United States for specifically interventional trials. There are actually 130 different studies that are actively recruiting. Beyond that, there are more that are active that are not recruiting patients that have finished recruiting, or they're not recruiting yet. And you'll see there the breakdown I gave of those 130 of the different phases. So most are in phase 1 and 2, although there are some 14 in phase 3 that are currently recruiting. And this is just in the United States. There are more across the world also. Okay, so I'm going to now move on to discuss specifically some of the therapies being studied. I'm going to start with some of the symptomatic therapies. So again, these are the ones that improve symptoms or are used for treating certain complications of Parkinson's disease or in certain scenarios, but not affecting the underlying disease. So among those, there are several that are being evaluated for improving motor fluctuations or the on-off periods. Some subcutaneous forms or under the skin forms of medications, also a different type of pill that delivers carbidopa-levodopa, as well as some procedures, including gene therapy. There's also a drug that I'll discuss that is being evaluated to help treat the dyskinesia or the extra movements. And as I mentioned before, MRI-guided focused ultrasound is available for tremor in Parkinson's disease, but it's also being evaluated for use in these other purposes. So for motor fluctuations or the on-off periods, one of the strategies that's being investigated is a subcutaneous or under the skin infusion of carbidopa-levodopa. So rather than taking your pills intermittently throughout the day, this is kind of on autopilot and delivering, a constant and regular amount of the drug over time. So this is similar to the idea or similar concept as the intestinal gel or pump or duopa, in that it seeks to eliminate some of the off times by giving a continuous infusion of the drug. It's just really a different delivery under the skin. So there are two compounds right now that are actually in phase 3 that are recruiting. I will show specifically or highlight that at the Medical College of Wisconsin, we are enrolling for this top drug. Want to make note that to be eligible for the study, you need to have an average of 2.5 hours of off time during the day. Perhaps similar, another subcutaneous or under the skin infusion is not carbidopa-levodopa, but it's apomorphine. So I mentioned that earlier with the injections and the under the tongue form as rescue therapy, but it's also being evaluated for a more continuous infusion to help prevent the off periods and the fluctuations. So this has completed clinical trials already. It did show some reduction in the amount of off time during the day. However, it's not FDA approved. It is being, just to note, it is being used in Europe though. And then finally, the new type of pill or carbidopa-levodopa formulation that can be used to, or the idea is to help minimize the fluctuations, is something called the accordion pill. This is a multi-layer film that has both immediate or short release and controlled release levodopa in it, with the idea that it provides a more smooth or even level of the drug in the body over time. This did already complete a phase 3 study. It was called the Accordance trial. Showed that it treated Parkinson's symptoms, but it didn't actually improve off time compared to regular carbidopa-levodopa. It's a little unclear. There's some talk that another phase 3 may be coming. The researchers, when they looked back at the data, it looked like the patients in the study may have needed actually higher doses than what were used. So we'll see. This may be needing some more research before it moves on. And then again, I mentioned the other procedural strategies for minimizing motor fluctuations. Gene therapy is being studied. Now, the concept of gene therapy, there are several different strategies being evaluated with different genes and for perhaps different purposes. What I'll focus on are the one that was maybe the furthest along, and that was looking for improvement in the motor fluctuations. And so this was a surgical procedure, basically introducing a healthy gene in the envelope of a virus that's not going to infect you, it can't get you sick, but basically it's just an envelope to get the gene into the brain. You can see the picture, the arrows show basically a surgical tract, and the bright white there is where they tagged it with a marker so we could take a picture of it where the gene was delivered. And so it's put into the brain in a region that's impacted by Parkinson's disease. And this gene specifically, the AADC gene, the idea is that it allows the brain to produce more dopamine. So this did already complete a phase 1 study that showed it was safe and did show some preliminary efficacy. Again, these are smaller number of patients, so it's not not the same as a phase 3, but the phase 1 looks promising. So this has moved on to a phase 2 study, and so that is active and ongoing. And as I mentioned, there are others in earlier stages that are using different genes or different combinations of genes, and also perhaps slightly different delivery or surgical techniques. Okay, and so all those investigative drugs I mentioned were really aimed at improving motor fluctuations. This one that I'll discuss is focusing on dyskinesias. So dipraglurant, I may or may not have pronounced that exactly correctly, so that's why I said it quickly. The goal of this is to reduce dyskinesia. It has completed a phase 2 already, showed it was safe and was preliminarily effective. This is moving on. So other studies on this, higher phase studies are pending. Okay, and now I'll end by talking about research on disease-modifying therapies. And so again, disease modification, what I mean by that is that we're changing the underlying disease course. So we're either slowing, stopping, or reversing the progression of the disease. There's a few different ways or strategies that we can go about that, including saving neurons that are dying, replacing those that have already been lost, or supporting other mechanisms in the brain that are making up for those dying neurons. As I mentioned, as it stands right now, we do not have any disease-modifying therapies. So this is truly a principal, or considered a principal unmet need in Parkinson's. So there are several different targets for disease modification. Not to get too much into the weeds here, I'll focus on the first two. So alpha-synuclein, which is the major component or main protein that accumulates in the brain in Parkinson's disease. So we'll look at targets that focus on that. Also, some other mechanisms that are non-alpha-synuclein related. I'll focus less on the latter two. So there are also some treatments that are being studied looking at specific genetic subtypes of Parkinson's disease. So a minority of people with Parkinson's, have a clear gene that we can identify that causes it. There may be some certain treatments that target that process or that gene that may or may not be applicable to the rest of the Parkinson's population. So that's why I won't necessarily focus on those. Okay, so alpha-synuclein, as I mentioned, this is a protein. It's a major component of the Lewy body. A Lewy body is the aggregation or the clumping together of this protein in an abnormal way in Parkinson's disease. So this is really a hallmark feature. So different ways that we can they're being investigated to target alpha-synuclein. One of which are an immune process, so using an antibody treatment. So what the antibody would do would find and bind the alpha-synuclein so that the immune system can clear it from the body. Right now, there are 2 studies in phase 2 looking at this mechanism, both of which are IV infusions. There are some earlier studies happening also. I'll mention that the Medical College of Wisconsin is involved in one of these studies. However, we are not enrolling in that study at the present time. Separate mechanism that looked at targeting alpha-synuclein was a drug called nilotinib. This is something that was already out on the market. It was a chemotherapy drug, but it had some biochemical basis for why it could work in Parkinson's. I'll just in case anyone was looking or following this in the news, it did complete a phase 2. Looked like it was reasonably safe, but it didn't seem to be particularly effective. So it doesn't look like this is going to be continuing in research. Finally, there are other drugs used for other purposes that have different mechanisms beyond alpha-synuclein. I'll mention some of these. Again, some of these you may have seen in the news. Is radipine is a calcium channel blocker, or, typically a blood pressure medicine. That finished a phase 3, but did not look like it was effective. Inosine is an antioxidant. Likewise, doesn't look like that was effective. However, there's some others that are still being evaluated. One is an iron chelator that has a couple of phase 2 trials going on. And then actually exenatide, which is a diabetes treatment. The exact mechanism in Parkinson's is a little unclear, but it's being studied, or chemicals like it are being studied in a few different trials. Again, mention that we do have a phase 2 study here at MCW that is enrolling. And then finally, just a brief mention, there are other mechanisms that are being explored somewhat in early stages. So stem cells, very early here, there are a lot of questions. There are a lot of different different ways that the stem cells are derived, different ways that they are given, different locations. So there's a lot of questions here, although this is an area of active research. Anti-inflammatory compounds are certainly something that are being studied also. I mentioned or just put up one that's being considered here. Again, those studies are ongoing. And then finally, exercise, physical therapy. So we all know that exercise and PT can be very helpful for those with Parkinson's disease. But there's actually some research going on, trying to see whether it actually impacts the disease course, or it can have some impact on the progression. So some very, very interesting things going on. So in summary, there is a lot of research happening for Parkinson's disease, not just here in Wisconsin or the United States, but around the world. And so I hope that you can all be hopeful and be excited for everything happening. And thank you, and I'll conclude my talk there.
Thank you, Dr. Jackowiak. I'm sure people appreciate it. I know as the questions came in, we had a lot of questions. So I'm going to jump right into those right now. One of the first questions that came in was a little bit about how do you define off time, and what does that look like for an individual?
This is actually, it might seem obvious, but it's not. So one person's off is not the exact same thing as another person's off. For the purpose of my talk today, I was really focusing on motor off. So meaning that, you start to slow down, slower, smaller movements, you might have more tremor. However, we know that that's not all that's encompassed in an off time. So a lot of those non-motor symptoms can also come out in an off time. You might have mental fog, you might have a feeling of anxiety, you might have, sensory symptoms like tingling. There's a lot of things that can define an off period. There's actually some research ongoing now trying to develop different scales to really help define that a little bit further. But when I say off, at least in terms of the treatments for the motor fluctuations, I'm really meaning that the motor side, so slowing down, small movements, stiffness, and tremor.
Perfect. One of the other questions was, as a clinician, when is the right time for you and a patient to start talking about considering DBS or any other surgery options?
Yeah. So this is something I think there's no like one time where, you hit the point and you say, this is the time to talk about DBS. We've hit this landmark. I think it can be an open discussion when you have your relationship with your doctor, just depending on how things are going for you. But generally speaking, we think about deep brain stimulation when the medicines are just not doing a good enough job controlling the fluctuations. We don't use DBS if there's symptoms that carbidopa-levodopa doesn't work for. It's more of the fluctuations, or if there are side effects to treatment that we just can't treat you well enough because you can't tolerate the medicine, be that from the dyskinesias or the extremoms or other things too. And so there's not really a one simple answer. It's a little bit specific to the individual.
I appreciate that. I think all treatments are very specific to the individual, and I think you hit that very well with DBS. Yeah. Somebody asked a question, and I hope I pronounced this right, so apologize if I completely butcher it. Had a question about the role of trihexyphenidyl in treating Parkinson's disease.
Yeah, so trihexyphenidyl, the brand name is Artane. So I say Artane just because it's easier to say. It's an anticholinergic, which is, looking back in history, that class of medicines are one of the oldest things that were used to treat Parkinson's disease. And so it definitely has some benefit. However, in terms of the motor symptoms, so like stiffness, slowness, the dopamine medicines are better in that sense. The scenario in which I use Artane is for people who have tremor, that the dopamine drugs are just not working well enough. Because it can, in some people, it can work better for tremor than the other medicines. Now, the important thing, and sometimes we shy away from this, it has a lot of side effects, particularly in older people, one of which being even cognitive dysfunction or memory problems, bladder issues. So we have to use it cautiously. So I'll say it has a role, although it may be somewhat limited.
Perfect. Another question that actually came in a couple days ago when somebody registered. They said they read in the AARP magazine that Alan Alda talked about getting a scan done to diagnose his Parkinson's disease. And her question was, is there something new that is diagnosing Parkinson's disease? I assume she's talking about the DAT scan, but can you maybe discuss a little bit if it's not the DAT scan or what the DAT scan is?
Sure. Yeah. So, without knowing that, reading that story specifically, I can only kind of conjecture. I assume it is the DAT scan. The DAT scan is something, it's a nuclear medicine study. Basically, you inject a tracer into your blood, and we see where in the brain that tracer gets taken up. It specifically targets something called the dopamine transporter. And so we know that protein or that transporter is there's less of it in certain parts of the brain in people with Parkinson's disease. So it's one of those, what I mentioned, the biomarkers early in the study on ways to detect Parkinson's. It's one of those. It does have a role. The caveat with the DAT scan, it doesn't really differentiate whether this is Parkinson's disease or some other thing like the atypical Parkinsonisms that may be similar, but not exactly Parkinson's disease. So it doesn't differentiate from those. And as it stands right now, it's not really used as a marker. So like how much the dopamine transporter is gone, you can't really use it to determine severity. Although that is an area that's being evaluated and studied. So different physicians use DAT scan differently. I probably use it less than other people. In my mind, if I think someone has Parkinson's disease clinically, Parkinson's disease is still a clinical diagnosis. The DAT scan can support or not support the diagnosis, but you still make the diagnosis clinically. If my suspicion is high enough, I'm going to treat for Parkinson's disease with or without the study. But people practice differently. And so that's what I mentioned early on, is that different physicians might do different things.
Thank you. I'm going to wrap up with the final question. You mentioned clinicaltrials.gov in your presentation. I know we've shared Fox Trial Finder as well through Michael J. Fox, but somebody had asked, you talked about some of the studies that are going on at Froedtert. If we're a patient at Froedtert or want to know if we're eligible for that study, who would we contact and how would we know to do that?
Yeah, I think, especially if you're a patient here, the best way to do is if you're interested, if there's a specific trial you're interested in, certainly let us know. But if you're interested in participating in research, just let your doctor know. What I would do is basically we pass your name along to our research coordinators. If it's a specific trial, we would say that. And then you could have that discussion. They could review, are you eligible? They could talk about the trial in a little more detail, and then you can decide whether or not to proceed and consider taking part. But in general, I want to encourage people to at least think about it. Nobody's twisting anybody's arm. It's a decision that's personal, whether or not you want to take part in some of these studies. But as we need people to, in order to find new treatments and learn about new treatments. We rely on volunteers to take part in these studies.
Thank you so much for your time, Dr. Jackowiak. I appreciate you coming in and doing this in your first month here in Wisconsin. I'm sure people really appreciate it. It was one of the topics we were really asked for. We're going to take a short break. We'll be back at the top of the hour, but the one plug I'm going to give is pretty much every treatment Dr. Jackowiak discussed today is covered by a number of the pharmaceutical vendors we have. So please take the time to go visit them and learn more about those medications if you do have questions. Otherwise, we will see you back here at 11 o'clock or top of the hour if you're in a different time zone. Thank you.